Okay, so let's look at staging. Last time we were talking about grading. This time we want to look at staging of these cancers. And to be very quite fast, if we say if that is our tumor, then there are 4 stages. Yeah, there are actually 5 stages. There is stage 0, there is stage 1. There is stage 2, there is stage 3, and also stage 4. Now, with stage 0, it means that the carcinoma has not moved anywhere. It is still where it was initially. So, in other words, we say that carcinoma is in situ. So that means that it has not moved anywhere. It is still there where it originated from. So it is in situ. With stage 1, we mean that the carcinoma is limited to the tissue of origin, and it is localized. So we mean that it might have started there. But then it may be it moves to maybe to this area and that area and this area. So around there, yeah, around there. So we mean at that particular moment we say that the carcinoma or the tumor is in stage 1. So in other words, it is localized. And localized. It is localized and limited to the tissue, to the tissue of origin. So here we are saying that it is localized. And so with 2 we mean with 2 it means that it is limited to local spread. In other words, it might have started from here and then maybe it spread to these areas here. Then maybe around here and even here, So, but even then, that tumor is said to be, it is locally spreading, and therefore that is stage 2. In other words, it is limited to local spread. Yeah. So it is limited to local spread. So within stage 2, we are saying it is local spread. And in stage 3, it is basically, it has spread locally, yeah, but it has also moved to other regional places around. So in other words, like if this is our heart, remember that is our heart. So it might have spread to the heart, yeah. So in other words, these are the regional, and maybe spread to the regional, taken by the regional lymph nodes. Those are probably around there, yeah, and maybe around here to the diaphragm. That is called regional spread. In other words, it spreads to the region where it basically developed. And so with stage 3 we are saying regional spread, local and regional spread. So in other words, extensive local and regional, yeah, regional spread. And then with stage 4, it has gone to distant metastases, like maybe the central nervous system here, maybe the liver down here, and other structures, yeah, other structures. So it is said to be in stage 4 when it has had what we call distant. It moves, yeah, distant metastases, yeah. So that is basically what we call staging of a cancer. Now, the other thing we want to look at are the factors that influence the development of cancer, and those factors that influence the development of cancer are divided into, I think, about 5. Yeah, we have what we call environmental factors, and in environmental factors here we have things like chemicals. The different chemicals that we use, maybe the detergents, the medications themselves, the tobacco and all those things can predispose someone to having cancer. Physical carcinogens, things like ionizing radiation, the scorching sun, the UV light from the scorching sun, any kind of tissue trauma, any kind of chronic irritation to a place. All these can predispose someone to get cancer. Then the other one is viral carcinogens. There are viruses, certain viruses that we know that are associated with the development of cancer, like hepatitis B virus, human papillomavirus, HPV, human papillomavirus. All these are associated with the development of cancer. And also Epstein-Barr virus. This one you will find it especially in pediatric cancers. All those are viruses that are associated with the development of cancer, and so they are called viral carcinogens. The other one is commonly, very common, what we call Helicobacter pylori or H. pylori. This is a this is a bacteria that is associated with with peptic ulcer disease and gastric ulcer, and so it is associated with development of gastric cancer in the long run. Other things like obesity and the diet that we eat, the different preservatives, the contaminants, the additives, and the nitrates, and even the alcohols, all these can predispose someone to getting cancer. Then genetic predisposition. There are some cancers that run in families. There are some cancers that run in families, like for example breast cancer. If you have an immediate relative who has had breast cancer, there are high chances that you can also get or acquire breast cancer. Then issues of age. There are some cancers that are that are obtained among the aged, like for example prostate cancer. People who get prostate cancer are those who are 60 years and above. But on the other hand, people who get testicular cancer are people who are between 15 and 35 years of age. So age is also a determinant of acquisition of cancer. Then the other thing is immune function. People who are immune compromised, like people who have HIV/AIDS. These ones have, since they are immune compromised, then they end up with, they can have some cancers. Like for example, Kaposi sarcoma. This is prevalent among the immune compromised HIV patients. But also people who have got, organ transplant, any person who has immune suppression, because we know that our immunity plays part in some of prevention of some of these. So people end up with with cancer because of immune suppression. Now, how do we prevent the development of cancer? We have known the predisposing factors, and one of them are the environmental predisposing factors. So what you want to do is to avoid any known or potential carcinogens that you are aware about. So when you avoid these, then you reduce your chances of getting cancer. But also it is very important to know that early detection also plays part. So whenever we talk about early detection, there's a word that we talk about, and that word is caution. Caution. So each letter stands for something. Each letter stands for something. C stands for change in bowel habits or bladder habits. This if you notice any obvious changes in your bowel habits, then you want to seek medical attention very fast, because you might probably be having a bladder cancer for bladder habits, or colon cancer for bowel habits. Then A stands for any Any sore that does not heal, if you notice on your skin or anywhere, any kind of sore that has taken long without healing, that might be developing into cancer. U stands for unusual bleeding or discharge. So if especially people who have cervical cancer, uterine or ovarian cancer, these people tend to have an unusual bleeding or discharge. So if you notice that, you want to seek attention very fast. Then T stands for thickening or lump in the breast or elsewhere. Yeah. So if you notice, especially ladies, if you notice a lump in the breast, then you want to seek medical attention before it is too late. And then I stands for indigestion. If you all the time you're belching, you have these signs of indigestion, then it might be a sign that maybe there is a growing gastric cancer. And then O stands for obvious change in wart or mole. If you have a wart or mole on your skin and you see an obvious change, yeah, it changes all of a sudden, then that might be probably a sign that it's a cancer. So you want to seek medical attention. And then finally, N stands for nagging cough or hoarseness of voice. So if you have that nagging cough or your voice is hoarse, a hoarse voice, something like that, so you end up, you should be able to seek medical attention. Now, what are some of the investigations that are done as far as early detection of these cancers are concerned? They do things like mammography. Mammography, they get to the breast of a lady, and then they put it under a plate, and then they do X-ray. Yeah. So imagine if this is your breast. Yeah. And then so they put it on a flat surface, and then they squeeze it like that, and then they do an X-ray on that breast when it is flat. So that is mammography. They can do what we call a pap smear, and this is for cervical cancer. They can do rectal exam and test for occult blood for colon cancer. They can do colonoscopy and sigmoidoscopy. These are in radiological, investigations that are done to look under your sigmoid or even your colon to see whether you have any, cancer. Self-breast examination, this is recommended for ladies. It is done monthly, every after your periods, to detect any lumps, or even a clinical breast examination that is done by a clinician. Then there is a testicular examination. This is done strictly by men, especially after a shower, to detect any lumps within the testicles. And then skin inspection for any obvious lesions that might probably not heal. Now, the different diagnostic tests that we do in addition to those, we do a biopsy, and a biopsy is one of the definitive diagnostic tests that are done. We can do bone marrow examination, especially for hematological cancers. We can do a chest radiograph for a cancer maybe in the chest or lung cancer. We can do a CBC, complete blood count, to detect for any signs of anemia. We can do a CT scan. Now, a CT scan helps to even show us how far the cancer has progressed or has moved. We can do cytological studies, pap smears, tumor markers, liver function tests, MRI, among others. Some of these investigations you will come across, others maybe not until you join practice that you will be able to know what they are. Others you have come across them and you know exactly how they are used or what they are supposed to do. So with diagnostic tests, as we said, biopsy is one of the definitive tests that are done, and here they basically take a piece of that tissue that is suspected to be cancerous. Yeah. And there are types of biopsy. We have fine needle aspiration biopsy, where they aspirate the cells in that area. and then they later on examine them for cancer. Then there is incision biopsy, where they remove a part of suspected tissue from a larger mass. Then there is excision biopsy, where they completely remove the entire tissue and get a piece and then take for examination. Then staging. Here in staging, as we saw, was from 0 to 4, whereby 4 stands for distant metastasis. They get pieces from several areas where they assume or where they think it has moved to, and then they look under the microscope to see whether indeed it has moved there. So those are the types of biopsy. Now, with biopsy, having obtained the tissue, they do, they prepare the tissue ready for to look under the microscope. And here, paraffin and freezing are very, very important components. We shall not go into the details of that, because you will not find this being done, because, as we said, it is a specialty which is done by oncologists. But at least you should be able to know something about that. So the other thing that is worth mentioning, or that you should know about, is that people who have cancer always complain about pain. So pain is one of the symptoms that people with cancer complain about. And why does this pain occur? One, it occurs probably because of destruction of bone. Remember, if like example, if it is a metastasis to a bone, or if the cancer developed in a bone, then the bone is continuously destroyed, and as a result, pain is experienced. Or it might be obstruction of an organ. Sometimes the cancer grows too much that it obstructs other structures and bringing about pain. It might be compression of peripheral nerves, infiltration or distension of tissue. It can be as a result of inflammation or even necrosis, or even psychological factors like anxiety, fear, emotional when you're emotionally down, and all these things can bring about pain. Now, of course, we are going to look more, under palliative care, we shall look more at how pain is managed. But one thing that you should know is that pain can be managed using what we call pharmacological and non-pharmacological. So we can manage pain using both pharmacological and non-pharmacological ways. With pharmacological, we mean giving medications. Yeah? And with non-pharmacological, we mean things like relaxing, guided imagery, massage, and all those things. We shall look at them more during in palliative care during management of pain. So we are not going to go into the details of that, but you have the presentation, you can read about it. So let's talk about the modes of what we call the treatment modalities. So in treatment modalities, we mean that someone who has cancer, what are some of the treatment options that they can have? Yeah? And so there are basically 3 treatment modalities. One of them is surgery. Then we have chemotherapy. And then 3, we have what we call radiotherapy. So those are the treatment modalities that anyone with cancer usually undergoes. But it's not a must that they should undergo through all of them, as we are going to see. Yeah? Okay, so starting with surgery. Surgery is indicated to diagnose, stage, and treat certain types of cancer. So in other words, we do surgery to do three things: either diagnose, treat, yeah, or even stage, certain types of cancer. And there are types of surgery that you should be aware about that are done in such patients. And one of them is prophylactic. By prophylactic surgery, we basically mean that it is performed to prevent someone from getting something. Yeah, prophylaxis, we usually take prophylaxis to prevent us from getting probably a particular condition. So with prophylactic surgery, we are doing it to prevent someone from getting something. So it is performed in clients with an existing pre-malignant condition or a known family history of genetic mutation. Yeah? Like for example, there is a popular American artist, Angelina Jolie, who had the family had a family history of breast cancer. So she opted to remove the breasts, yeah, because she suspected that she would develop breast cancer. So this is what we refer to as prophylactic surgery. So someone, a condition or known family history or genetic mutation that strongly predisposes the person to the development of cancer. So this is what I have been saying. Then it can also be curative, whereby you remove the diseased tissue and then someone gets well. That is what we call curative. And then in control surgery, a debulking procedure that consists of removing a large portion. Yeah? So here in control surgery, we basically want to prevent things like complications. Like for example, you have a very big tumor. Let me say this is the tumor, yeah, and it is maybe compressing maybe the aorta or maybe a blood vessel. So you kind of like debulk it, or you remove it so that the blood vessel stays patent. Yeah, you remove the tumor so that the blood vessel stays patent. So that is what we call control surgery, or sometimes it is basically helps to debulk or remove a large portion of a locally invasive tumor. Yeah, and then we also have palliative surgery. This is usually also performed to improve the quality of life during survival. So in other words, it is not curative, but it is performed to kind of like prolong someone's life or improve the quality of life. And then we also have reconstructive surgery, and this is performed also to improve the quality of life by restoring maximal functioning and appearance, such as breast reconstruction after mastectomy. So that is basically surgery. While the adverse effects of surgery, you have loss of function, reduced function as a result of organ loss, scarring and disfigurement. We have things like grieving, and then pain and infection. Those are some of the side effects of surgery. Then we also have chemotherapy, and with chemotherapy we say chemo. So with chemotherapy, we are saying that the person is being given medication. Chemo stands for medication. So they are given anti-cancer medications, and these help to either inhibit or even kill, yeah, or they kill or inhibit the multiplication of these cells, yeah. So usually the effects are systemic. In other words, they are evidenced throughout the whole body, because it is usually administered systemically. So it is, in most cases, it's given via an IV line. So normal cells are most profoundly affected, and when you give chemotherapy, it's not that the medicine is specific to that particular tissue, but there are other cells that are affected, And in the long run, some normal cells can be affected, and mostly what is affected are what we call the rapidly growing cells. Yeah, the rapidly growing cells. Like for example, the skin. Yeah, this skin that you have all the time, it is shedding. Yeah, and so the cells are rapidly growing. So when you give chemotherapy, there is a way that it also interferes with the normal functioning of of the skin cells. So there are normal cells that are profoundly affected. Like for example, the skin, the hair, the lining of the GI, the spermatocytes, and then the hemopoietic cells, because these are fast growing cells. They are normally fast growing cells, and so when you give a chemotherapy agent, it ends up affecting it as well. So usually severe chemotherapy and biotherapy agents are used in combination. Yeah, so usually they combine. They are combined. It's a combination. And of course, this combination is provided, or it is planned by the healthcare provider. Yeah, and however, it should be put into practice that it should not be given. It should not be given whereby when those two medications have what we call overlapping toxicities and nadir. Yeah, a nadir is that time during which the bone marrow activity and white cell production are basically at their lowest rate. Yeah, so they are not administered to when they have the same toxicity and the same nadir. So chemotherapy is usually combined with other treatments such as surgery and radiation. In other words, they don't do chemotherapy alone. Yeah, they can add it with radiation and surgery. The common side effects basically include fatigue. Alopecia means loss of hair, because remember we said the fastest growing cells are affected, and hair is one of them. So the person ends up losing hair. Vomiting and nausea because of GI is affected. We have skin changes, myelosuppression, and all those things. All these side effects are seen in those fast growing cells, as we said earlier on. Now, the last modification, the last treatment modality is chemotherapy. Is radiotherapy. And radiotherapy basically destroys cancer cells with with minimal exposure to normal cells. In other words, with radiotherapy, they direct the beam. Yeah, they direct the beam where the tumor is. So in other words, there is minimal exposure to normal cells. Yeah, and so the normal cells are not affected as much compared to chemotherapy. So the damaged cells die and become unable to divide. In other words, the tumor cells, when they are irradiated, they die eventually, and then they become unable to divide. So radiation therapy is effective on tissues directly within the path of the beam. This is what we are saying, that if maybe the tumor is here on someone's body, if the tumor is there, then the beam from a machine. The beam from a machine is directed to this, is directed to that tumor there. Yeah. So those if this is our machine, so this tumor here, so this radiation is works on this tumor here that has been radiated. So that is what we are saying, that radiation therapy is effective on tissues directly within the path of the radiation beam. Yeah, something like that. And the side effects include local changes in the skin and irritation, alopecia, fatigue, among others. Yeah. Now, radiation is basically divided into two. There is what we call external beam radiation, also called teletherapy, and then we have internal beam radiation, which is called brachytherapy. And these are the two types of radiation that I use. Yeah. Now, with external beam radiation, this is what something like that. In other words, the machine is outside, yeah, and then they direct the beam to the lesion, something like that. Yeah. So the actual radiation source is external to the client. So what you do is instruct the client regarding skin care, and also the client does not. It should also be known that the client, when they are finished, irradiating the client does not emit. Yeah, the client does not emit any radiation. In other words, the client is safe to move around and all those things. Yeah, that is what we mean by external beam radiation or teletherapy. The other one is brachytherapy, and brachytherapy is basically internal. Yeah, so the radiation source comes into direct continuous contact with the tumor tissues. Like, for example, patients who have cervical cancer, they put the source within the vagina. Yeah, and so the source, the radiation source, comes into direct contact with the tumor tissues for a specific period of time. So the radiation source is within the client for a specific period of time, and the client emits radiation and can pose a hazard to others. And for this case, it therefore means that the client should be isolated and put in an isolation room or a separate room, so that they don't pose threat to others. So it includes what we call an unsealed source or a sealed source of radiation, as we are going to see. Now, what do you do, or how do you teach a client who is for radiation? Basically, for external radiation, those are some of the things that you need to do to teach a client. One is wash the irradiated area gently. So for an external radiation, these are the things that you teach the client. Please read about those ones in detail. And one is you wash the area gently each day with warm water alone or with mild soap. Use a hand, rather than a washcloth when you're washing, the area that is being irradiated. And then dry the area by patting motions. By patting motions, we mean like this, yeah? Patting motions, yeah? Dry the area with patting motions. And then use no powder, and then wear soft clothing, and then avoid wearing belts or buckles or even straps in case the radiation site is in that area. Then avoid exposure of the radiated area to the sun, yeah, or even heat for that matter, yeah. So that is when the beam is external. Now, remember we said for brachytherapy, the beam, the source of the radiation can be sealed or unsealed. Now, for unsealed radiation, administration is via oral or IV, yeah, route, or by instillation into body cavities, yeah. So that is what we mean by unsealed, yeah. And so the source is not confined completely to one body area, and it basically enters body fluids and even excreta, yeah. When you have stool, the source of the radiation is actually there. So and so all these can be harmful. So most of the source is eliminated from the body within 48 hours. Then neither the client nor the excreta is radioactive or harmful. So after 48 hours, this person is not harmful at all if an unsealed source has been injected into this person. Now, how do you care for someone who has a sealed radiation implant? Like, for example, I gave you an example of maybe someone who has a cervical cancer, and then they go ahead and put, let me just demonstrate. Just imagine this is the female reproductive system of a lady. and of course these are the tubes. This is the uterus, and then maybe the patient has a cervical cancer. Yeah. So what they actually do, and you know that this is the vagina. So they put the implant, they insert the implant in this area here. Yeah. In this area, they go ahead and put the implant. They put the implant in this area here. Yeah. Or sometimes they can even put it in this area here. Yeah. So what actually happens is that it stays there for some period of time. Yeah, it stays there for some period of time. So how do we care for such? How do you care for such patients who have who have an implant? So you place the client in a private room, then place the radiation precaution sign. Then organize nursing tasks to minimize exposure to radiation. In other words, make sure that it's not one nurse who always enters there. Yeah, minimize the time or the duration that you enter into that private room when taking care of that patient. And then limit the time to 30 minutes. Wear a dosimeter film. So they usually wear, as they enter, they wear a dosimeter film. Yeah. A dosimeter film badge that basically measures the amount of radiation exposure. And then lead shielding may also be used to reduce exposure. Then the nurse should never care for more than one client who has such. And then do not allow a pregnant nurse to basically care for such a patient because of issues that have to do with irradiation. Then children who are younger than 16 or pregnant women should not visit. Yeah, should not visit the client who has a sealed implant. Then you should save bed linens and dressings. Yeah, of these people. And then the other thing is that other equipment can be removed from the room anytime. Yeah. So basically, that is how we care for a patient who has such. Now, a sealed temporary or permanent radiation source is implanted within the target tissues, as we saw, and then the client emits radiation while the implant is in place, but the excreta is not radioactive. Yeah, is that okay? Yeah. So how is the removal of a sealed radiation source? So a client, one removal of sealed radiation sources. How do you remove it? One, the client is not radioactive following removal. Yeah. So when it is removed, then the client is no longer radioactive. And then so inform the client that the cancer is not contagious. Inform the client to follow the prescriptions of the physician regarding resumption of sexual intercourse if it was within the vagina. Advise the client who had a cervical or vaginal implant to notify the healthcare provider in case they get severe diarrhea, frequent urination, urethral burning. These might be signs of a UTI. Yeah. Or they might be adverse effects of the irradiation. So you tell the client to inform the physician in case of those. Then the other thing that is actually also very important in the care of someone who has a sealed radiation implant, which is probably not in here, is that when it moves out, you should never put it back. Yeah. When it moves out, you should, or the nurse should never put it back and should never pick it, should never pick it with their hands. They usually use lead tongs and then they put it in a lead container, yeah, and then inform the physician who put it in earlier to be able to do it, to come back and probably insert it, yeah. So the nurse should never put back, the sealed implant in case it gets out of the patient. So basically that is what we wanted to cover today. In case you have any questions, please make sure that you raise them. Other than that, I want you to look at the video, be critical, watch it over and over again so that you can easily understand some of these things. Thank you so much for having listened to this video, and we shall meet yet again for another video. Thank you so much.